Hi, I'm Dr. Neha Gupta, Senior Infectious Diseases Physician in Delhi NCR, and I'm an expert in tuberculosis, HIV, infections across various specialties, fever, prolonged fever of unknown origin, and for prevention of infections, which includes vaccination. So today we are going to discuss regarding MDR TB. What is MDR TB? It stands for multi-drug resistant tuberculosis, that is when TB is resistant to isoniazid and rifampicin. When MDR TB is also resistant to any of the fluoroquinolones and any of the injectable drugs which are used for treating TB, it becomes XDR. That is, it is a more resistant tuberculosis. And we also have a XDR TB, that is when TB bacilli is resistant to all the drugs which can be tested in the labs. So is MDR TB common in India? Yes, indeed. There has been, over the last few decades, there has been a gradual and steep increase in the drug resistant tuberculosis in India as well as across the world. In fact, depending upon what is the site of infection, the rate of MDR TB probably would be somewhere between 20 to 30% among the TB patients. So it's very important to identify drug resistant TB. And how do we identify? It's usually a patient who has been started on anti-TB drugs is not improving. That's when there is a suspicion of MDR TB. We should make appropriate measures to diagnose it, because there are certain non-infective etiologies or some other infections also which can mimic TB. So when there is a patient who is on anti-TB drugs or is a patient who is presenting like TB, the first question is whether it is TB, and second is whether it is a MDR TB. And when we talk about what are the various non-infective causes or what are the various infections which can mimic tuberculosis, so we have commonly typhoid, brucella, fungal infections like histoplasmosis, and some other infections which can mimic TB like milioidosis, and non-infective causes like patients with sarcoidosis can have similar features which may mimic TB. It can also be because of certain autoimmune condition, vasculitis like vaginous granulomatosis, and certain other not very typical organisms like nocardia or even atypical mycobacteria can mimic TB. So these are the various differential diagnoses of TB. And before starting MDR TB regimen, we must always exclude the various other possibilities. So to make a diagnosis of MDR TB, we have certain tests which can help us. We also have radiology which will be effective and can give a clue towards that this looks like tuberculosis radiologically, and then subsequently we must have microbiology as well as histopathology in place. So microbiological tests include usually AFB stain, AFB culture, which is TB midget culture. We can do molecular assays like the expert MTB, expert MTB ultra, which have a higher sensitivity for picking up tuberculosis. And then of course pyrosequencing, which can also be performed from the liquid or from the pus, which will help us in detecting the tuberculosis as well as in identifying what is the mechanism of resistance. So it will help in identifying the MDR TB. Now, how do we treat these patients? The treatment of MDR TB is different from the treatment of tuberculosis or the susceptible TB. So we have first line anti-TB drugs which work for the susceptible TB, and we have second line or we have drugs for the MDR TB regimen, and this treatment includes injectable drugs which the patient has to take for a long period of time, sometimes 4 to 6 months. It includes drugs for a much longer duration. Usually for susceptible TB we have treatment for 6 to 9 months or a little longer, maybe up till 12 months for bone and brain TB. But for MDR TB it is usually longer of 18 months or 24 months. So there are drugs which are injectable. There are multiple drugs, at least 4 to 5 drugs, which are likely to be effective, and it's a longer duration of therapy and requires a more continuous monitoring. These drugs are a little more toxic, little more difficult to tolerate, so a regular monitoring of the various blood tests, liver function tests, creatinine, audiometry, all these need to be done. Besides, a thyroid profile also needs to be checked on a regular basis, and it's very important to take all the drugs in the right dosages, because it's important to achieve a good concentration of the drug at the site of infection, especially if we are dealing with a MDR TB in the brain or in the bone, where the penetration of these drugs is a little compromised. And coming to prevention, how can we control or prevent MDR TB? So the most important aspect in prevention is that if there is a patient with TB, especially lung tuberculosis, early detection and early initiation of the right anti-TB drugs to interrupt the transmission is extremely important. Even if it's susceptible TB, if the drugs are not taken properly, either if they are not in the right dosages, or if the patient does not take them properly, like misses the drugs, then the TB bacilli is exposed to suboptimal concentration of these anti-TB drugs and may acquire resistance. Suppose the patient is taking only quinolones like levofloxacin or some other drug as a monotherapy, or some other anti-TB drug as a monotherapy, then if suppose the patient is exposed to it, or the TB bacilli is exposed to these drugs for 2 to 3 weeks as a monotherapy, it will acquire resistance. So it's very important that drugs should be taken in the right dosages, and combined or multiple drugs have to be taken together with full adherence, with close monitoring of the various side effects. Again, the treatment needs to be taken for the prescribed duration. One should not stop the therapy if there is improvement in the symptoms, because then there will be chances of relapse. Improvement in the nutrition, a good diet is also very important. A high protein diet, correction of the various vitamin deficiencies like vitamin D, vitamin B12 is also important for improving the cure from tuberculosis. And at the same time, I think most important is that we must identify, suspect early, and in case there is a person who is having cough, then for a long period of time, say more than 2 weeks, then there should be a suspicion for tuberculosis, and appropriate measures like cough etiquettes are very important to prevent the transmission from one person to another person. Thank you so much.